So I'm Mark Albert. Welcome everyone to the July ASJ Journal Club presented by the Young Aesthetic Plastic Surgeons Committee. Tonight we're going to be discussing the article, The Ponytail Lift, 22 Years of Experience in 600 Cases of Endoscopic Deep Plane Facial Rejuvenation. So before we begin, we encourage you to please ask questions in the chat box, make comments. We always love if you turn on your video at the end, make a comment, ask a question. The more interactive, the better. So tonight I'm joined by Dr. Deniz Sarhaddi. She's going to be presenting poll questions to all of you, and then she'll also relay your questions from the chat box to our speakers at the end of the session. So I'm going to begin by introducing our speakers, and then I'll turn it over to Dr. Kao to share his screen. So our author tonight is Dr. Chia Chi Kao. Dr. Kao is an internationally recognized board-certified surgeon with over 22 years of experience. He's the founder of Kao Institute in Santa Monica, California, and he's also the creator of the Ponytail Lift and the Ponytail Facelift, which we're going to be discussing tonight. He graduated from the medical school and general surgery program at the University of Washington. He then became a clinical professor at the university's Center for Video Endoscopic Surgery before completing a 3-year plastic surgery program at USC. Dr. Kao has been a regular nationally and internationally invited speaker for the Aesthetic Society, for ISAPS, for BTS, ASPS, and AAFPRS. And Dr. Grady is our discussant tonight. Dr. Kaur completed medical school at University of Arkansas and general surgery at Einstein in New York. He practiced general surgery before going back for plastic surgery training at Mayo Clinic, and he did an aesthetic fellowship with Dr. Louis Vasquez. Dr. Kaur is the co-inventor of the endobrow procedure with Dr. Vasquez, and he first presented the endobrow technique at the annual ASPS meeting in 1992. He was formerly chief of plastic surgery at Oxnard Clinic in New Orleans until moving to Birmingham in 1996, where he founded Core Plastic Surgery. His practice is dedicated to minimally invasive plastic surgery with endoscopic techniques. So thank you, Drs. Kao and Core, for being here. And let's get right into it. I'll turn it over to Dr. Kao to share his screen and discuss his article.
Okay, thank you very much, Mark. And I appreciate Grady and also my co-author, Dominik Duscher, and he's here as well. And I just want to thank you very much. And most of what I do is really stand on shoulder giants. And these things were developed in 1992. The endoscopic brow was with Grady and Louis Vasquez and also Nicanor Issei. So much of what we do is much more extension of that. So I'll just get into it right now. So when I first started doing this, when I recognized there was something that I was doing in residency that was taught in plastic surgery, the traditional facelift, and these things that I saw I didn't like. Of course, these are severe cases of a lateral sweep and amputated sideburns and a blunting of the tragus. And these are just kind of stigmata of facelift that I saw that I wasn't really liking as I was learning was in resident. And also, when you do a bilateral approach to separate the skin away from the fat, separate the fat away from the muscle, that you end up also devasculating the skin. And you can see these facial telangiectasias can form after these kind of separating procedures. And we all recognize that this is not something that is so uncommon that we don't see. I think every plastic surgery, every facelift surgeon can recognize that these kind of issues. And of course, in the neck, the problem with the neck is it can have severely over resected neck and also neck banding and scar tissue formation. These are some of the things that we all see as plastic surgeons. And we're going to be discussing this paper, which took me, this is my lifetime's work. Since I started in 2000, after I graduated from USC plastic surgery, I started my private practice in 2000, and I kept track of every single one of these cases until 2022. And I accumulated about 600 cases. And it's really it's a deep plane. What it should be called endoscopic deep plane, total deep plane facial rejuvenation. And So there's a ponytail lift and ponytail facelift. And ponytail lift is an endoscopic brow rotation, a cheek lift, an endoscopic platysma smash cranial suspension gel lift, a skin-only lower blepharoplasty, fat transfer to the face, and some kind of resurfacing of the skin, either with CO2 laser or 15% TCA peel. And a ponytail facelift is all that plus removing the skin. We do a limited incision lower lower face and neck lift, and neck with the anterior neck palpation and posterior corset. And we had a total of 600 patients. Most of them are female, 95%, and male with 5% was in my practice. Average age range around 50. So the youngest is 17, the oldest is 82. And you see the incision and the extent of the section we use. The incisions are for the ponytail lift type 1 and type 2. The incision is 2 endoscopic access incision in the temporal and the perimedian area of the scalp. And then for type 2 is when patients have a little bit of a cherubic face. They need to thin out the lower face and the neck. We add a little endoscopic incision behind the ear lobe to access the lower face and the upper neck area. And then if we need to, the deep contour anterior neck is a submental incision. And so that's the ponytail lift. A ponytail facelift is now we're going to remove skin from the neck and the lower face, because there's a lot of it. There's older patients now, and you can see the section we're going to open up just the posterior aspect of the incision into the mastoid area, and the dissection is all the way down to the clavicle, all the way back to the trapezius. The very, very extensive undermining of the skin, and then we also go into the subplatysmal plane and tighten the platysma.
Record progress.
And for patients who are much older, have laxity of skin, and when we try to put it all in the back of the neck area, and it creates a little either a dog ear or excess folds in the preauricular area. We kind of need to flatten that out. We have to chase that dog ear up a little bit, and so we sort of do a pre-trago incision there to flatten that out, and that's what we call a ponytail facelift type 2. Okay, so most of our patients is type 1. Some patients, when they're much older and they have a lot of skin, we have to remove a little bit of skin there. That's the type 2. So in these patient groups, ponytail lift type 1, we had 197 patients, mostly female, and the age range is 42. Ponytail lift type 2, you see only 12 patients, and the average range is 41 years old. The reason for that is because people don't understand, they don't realize we can do this all endoscopically. Type 2 ponytail is very, very special because it's all complete endoscopic, basically from the top of the head to the neck. And people don't realize that, so either they wait a long time until they get enough to remove, so it becomes ponytail facelift type 1, and we had the most is 257 out of the series, and the average age is a little bit older, of course, is 54, and then on the ponytail facelift type 2 is 134 patients, and the average age is 57. And this is a total deep plane endoscopic approach. And it's also, we should add, it's really a total endoscopic preservation deep plane, because we actually preserve all the vessels to the skin as well. So in the forehead area is a superior, we're operating in a superior ostial plane, and the temporal is a subTPF plane, and then in the face is a submass or deep plane, and then in the neck is both a combination of subplatysma and a subcutaneous dissection. And then once we free everything up, then we're gonna do a series of cable suspension sutures, which I call, they're in different levels because it's going to be a progressive tension sutures. So we have level 1's around the zygomatic arch in the cheeks, and level 2 is what we call is in what we call a temporal patch. We'll explain a little bit later. And a level 3 is the cross cable suture between the two temporal incisions of the temporal cable sutures, and then the paramedian incision. That's a level 3 suture. So when these things are added together, level 1, level 2, level 3, there's a progressive tension suture to move the face vertically up. The face flap is vertical, and also is also central rotation of the facial flaps. So the sequence, if we're going to do a ponytail facelift, the sequence procedure is very, very important, because we're going to do the delicate stuff first, and we have to maximize the vertical vector and also the central rotation of the skin flaps. So we're going to do a skin-only lower blepharoplasty first, then we're going to do a limited incision lower face and neck lift from laterally. And once we've done that, we're going to do a deep contouring anterior neck structures. We're going to do the subplatysmal fat. We're going to contour the anterior belly digastric, plus or minus submandibular glands, and then we're going to do anterior plication of subplatysmal bands, so anterior corset. Then we're not going to fix anything just yet laterally. Then we're going to go up to the top. We're going to do endoscopic forehead lift, brow rotation, deep plane cheek lift. And then once that's done, I'll suspend it. We'll come back down to tighten the SMAS and platysma laterally as a posterior corset. And then once we've done that, then we're going to do redraping the excess skin in the neck, tailoring the posterior auricular incision or pretracheal incision if needed, and then a meticulous closure is performed. And then after everything is set, then we do a micro fat grafting for volume and shaping, and then we do a sniff technique with micronized fat or for deep wrinkles and retexturization. And finally, we do a skin surfacing either with a TCA peel or fractionated CO2 laser. So that's a sequence of our procedure. And so to kind of just take you through it, so we're going to do a skin-only lower blepharoplasty here, and this is a skin pinch, and no apicularis is removed. And usually we can get about 8 millimeters, sometimes to 10 millimeters, safely without ectropion, because we're going to do a cheek lift in conjunction with it hours later. And so this is our subcutaneous dissection. It's very extensive. It's performed from a line drawn from the ear to the ala of the nose, and then we're going to dissect down all the way down to the clavicle inferiorly, and then we're going to go back posteriorly to the trapezius. And then once that's done, we're going to go into deep plane. So we're going to dissect in the subsmass and subplatysmal layer, and we're going to be dissecting 2 centimeter to the anterior border of the masseter, beyond the anterior border of the masseter, releasing the fixed mass and lifting the mobile mass. And then the subplatysmal dissection is going to be contiguous from the deep plane dissection of the lower face down to the neck. And this will be 4 centimeter below the jawline, about 4 to 5 centimeter medially to free up the platysma. And here's the
reason
video.
we're in a deep plane here. Here's the SMAS right here. The SMAS is right here. Okay. Then we're going to sub-SMAS here. The sub-SMAS dissection is here. Move it all the way down across. Look at that here. That's the extent of the dissection. Across the anterior border of the masseter muscle. And the amount of subcutaneous dissection, which is here, is along here. We don't go above this line. Okay. So this is all dissected all the way down subcutaneously. Keep the fat with the skin all the way back here. You see the extent of our dissection. It connects to the other side.
So that's the extent of the subcutaneous and the deep plane dissection. And then this is the endoscopic version of that through a ponytail lift type 2 with a little incision behind the ear. So this is our dissection from behind the ear, endoscopic access, releasing the mandibular ligaments in the subcutaneous space. Okay, and then we're going to go into the deep plane now in the submass level endoscopically. You can see how beautiful the anatomy is through the endoscope. And we're dissecting, we're going to be dissecting beyond the anterior border of masseter. And we're going to keep going. You can see there's muscle fibers there. There's definitely a structure there. I know there's been a question of whether there's a SMAS beyond the masseter.
Anterior border of the masseter. So we're now beyond the anterior border of masseter now into the mobile SMAS.
So there's been question in our society whether we have a SMAS there or not, but I think we do. So now we're releasing the fixed mass into the mobile SMAS. So once we've done that, we're going to leave everything. We're going to go to the anterior dissection of the neck, and this has been well described by many authors, Andre and Tim, Martin, and Jerry O'Daniel. We're gonna go after the subpituitary fat, anterior digastric, and the submandibular glands if we need to. The only difference that I do here with the glands is that my incision is very, very anterior, near the chin pad, because the scar seals better in the chin pad rather than the neck. But it makes this dissection more difficult because you're really operating the keyhole. But to me, it's worth it because you don't see the scar. You don't have a stigmata of a surgery in the neck. And so now once that's done, we're gonna go upstairs to the brow portion of it. Okay, so we're gonna start the endoscopic brow part of it is that I call brow fashioning because it's not as directly as a brow lift. So when I look at the brow, the brow, the forehead, and the brow musculature is in the lids, upper lids, it's all one aesthetic unit. Forehead, brow, upper lid, and eyes, the corner eyes, all one aesthetic unit. And so this is very important because when we do the brow, these structure has to be released in order for us to have a successful brow lift or brow rotation. So we have to release the superior temporal septum, the inferior temporal septum, temporal ligaments adhesion, lateral orbital thickening, zygomatic arch ligament, and the glabellas. These has to be released properly in order for us to have a good brow lift that is sustaining for a long time. So this is superior orbital septum.
Nothing here. There's a little tiny vein at the bottom of this.
Temporal fusion line. It's very thick. Here we go all the way down to the orbital rim. That's the first one we take down. The second we take down is the inferior orbital septum. So this is a very, very loose areolar tissue here. And when you see the little yellow fat, that's the separation between the anterior and posterior leaflet of the deep temporal fascia. Okay, so this is where just above in this area, we're going to be conscientious of the frontal branch of the facial nerve. That's when we start getting into that area. So this temporal ligamentous adhesion, and this is right at the orbital rim, and this is very thick ligamentous attachment. Okay. And that tissue is very, very hard to dissect. And it's very hard to release with a periostal elevator. I had to switch over to a scissor to release and really expand that area out in order for the brow to be able to be released and rotated. So this is where the endoscopic brow failed. Is right here, the failure to release this ligament. Okay, so we have to be able to do that, and to switching over the scissors is very, very important in our dissection. And then this is a lateral orbital thickening. So when we do this, is or to rotate the corner of the eye up, like the whole sort of fox eye praise, that you can release the lateral orbital thickening. You can turn the eyes up so they look a little bit more exotic or they look prettier and so forth. And people with with extropion or downward turning eyes, this could help them a lot. And then the lateral arch ligament, and this is for us to release here with the scissors. It's very thick. We have to watch out for the superficial temporal artery and vein here. And now through this dissection, we can actually continue this dissection all the way down to the lower angle of the jaw as well, to perform what we call platysma mass, endoscopic platysma mass cranial suspension. So we can actually go down to the lower face from here. And then for the galea, we have to release the galea. Obviously, this is on the right side. This is the lateral to the supraorbital artery and vein and nerve, and so we have to release that along with that temporal ligamentous adhesions there. So this is all has to be released properly. So that's the forehead dissection and most of the temporal dissection. But in the temporal area, the anatomy is very refined because there's a temporal crest vein that's along the temporal crest that we saw earlier. Is a bottom temporal crest. It was previously unnamed. Then we have the sentinel vein. Then we have the lateral and medial zygomatic temporal neurovascular bundle. And these two bundles, they point up to the course of the frontal branch of the facial nerve. Now, I've seen a lot of, I was at a meeting just 2 weeks ago, a week and a half ago, with ENT surgeons, and they were doing the brow, but they were doing dissection sort of blindly with their fingers and so forth, releasing the temporal area, and they caused a lot of bleeding and some injury to the sensory, these nerves and so forth. And it just, to me, that's unnecessary to have the packet and allow the bleeding to stop and so forth. And so it's much better if you can visualize this and go around it and preserve them. Because when you don't preserve them,
at the bottom of the temporal crest, right here. This is one right here. Bottom of the crest should be right here. Okay, so this is the sentinel vein, and this is the medial zygomatic-temporal neurovascular bundle here. It's here. And then this is the lateral zygomatic-temporal. These 2 points up to the course of the frontal branch of the facial nerve. So this is the telephone pole formation.
And this telephone pole formation is important because it really defines the anatomy of the temporal area, and it's actually something that was coined by Nicanor Issei, and this area a lot of times is obliterated by many surgeons who doesn't use the endoscope, and I like to preserve the sentinel vein, because when you don't, what happens, you lateral circulation that develops after that, and the patient get really veiny around the periorbital area, and they come back in the office complaining about that. And from there on, we're going to go into the mid-face area. So the dissection in the mid-face is actually just inferior to the temporal, to the sentinel vein, and we're going to be underneath the orbicular sacral muscle on top of the SUF, riding on top of the zygomatic major muscle, go across the nasal labial fold. That is the end. That's the end point of our mid-face dissection, is across the nasal labial fold. I'll show you again.
This is the lateral zygomatic-temporal, and then there's the medial zygomatic-temporal neurovascular bundle. And then we're going to continue dissecting down toward the midface here, and we're on top of the zygomatic major muscle. Carefully dissecting with the scissors here, keeping all the fibers down. Then we're going to switch over to the trip set. When we get down to the bottom of the body of the zygoma, continue dissection down across the nasolabial fold. And this is the platypus, which is a little bit more blunt, to help me do that.
So our endpoint of the session is across the nasolabial fold here. And that helps turn up the corner of the mouth, and helps the marionette line as well when we do this. And then once that's done, so here's the Now we begin the suspension suture, the progressive tension suture. So this is the level 1 suture here along the zygomatic arch. There's 2 of them or 3 of them that's placed along the arch ligament that we released. So we're going to use the natural ligaments and fibrous condensation of the face as handle to move the facial flaps up. And this is one in the cheek. Here you see we start moving the cheek up, and then there'll be another one where that little loose spot just above there. We're gonna put another stitch up there. So this is a progressive tension suture in the cheek and the lateral face.
Right here.
So everything is anchored to the deep temporal fascia. Okay, so there's usually 3 of them that's along the cheek there. And then now this is a level 2. Then this temporal patch. This temporal patch is releasing the TPF because if you take that skin hook and pull on the facial flap, the scalp flap there, it's not going to move a lot. So we're going to take a little square patch to release the TPF. So when we pull on that edge of that incision, that tension is going to be transmitted to the skin. So it tightens the lateral temporal area and rotates the lateral brow. And then finally, level 3 suture is that cross cable sutures of the temporal. So this is a free floating suture. We take a bite of TPF on one end, we pass both strands to the other side and take the medial aspect of the incision, taking the TPF on the other side. Okay, and then we don't tie it just yet. We clamp it, and then we're going to do the same thing for the paramedian incision to Galea, taking it in the posterior aspect of the incision, and then we're going to pass it along to the other side here, and take another bite there. So these are our 2 concentric cross-cable sutures here, and then once we got them set, then we're going to tie them with the assistance of with our system with the hooks pulling vertically straight up, and we're going to tighten these sutures. When we tighten and shorten the suture, it's going to rotate the brow and the temporal area, and it just maintains and stays there as long as we did a proper release in the glabella and the temporal area. So once that's tied, you see the brow and the forehead and brow, it just stays there. But it can look a little empty. So this is time where we're gonna add our volume restoration. But before we do that, the tying sequence is very, very important because we want to maximize the vertical and central rotation. So this is a sequence of tying. The tying first, we're going to tie the stitches along the zygomatic arch, and then we're going to tie the sutures along the cheeks, and then we're going to tie the suture between the bitemporal cable suture, and then we're going to tie the suture of the paramedian sutures, the cable sutures. So now we have elevated and rotated, and then we're going to tie the temporal island suture, and then we're going to close incision and then again pulling up and then suture into the deep temporal fascia. Once we've done that, then we're going to come back and then we tie the posterior corset to make so everything is tightened. So this is the sequence of tying. So maximize this vertical central rotation. So what we call is like a Fabergé vector. It's like an egg Fabergé vector. So that it's a vector that hasn't been previously described in facelift surgery before, because it's mostly vertical, but this is vertical central, Fabergé vector. So you see,
this is the arch. The interior arch used to be here. The interior arch is actually here. So this moved up about 2 centimeters. And the angle of the jaw, this is the old position, the new position.
So when we
this new
finish our
position,
progressive tension
moved
suture,
about 2
the
centimeters.
skin in
This
front
is
of the
the
ear
angle
and
jaw.
the lower jawline goes
So-
up by 2 centimeters here. Sometimes 2.5, as much as 3 I've had. So that's why we don't have to make an incision in front of the ear, because all that skin has been displaced superiorly, so we don't need to cut in front of the ear.
Laxity we get after we get the vertical tightening to the
So that's
T-plane
before we did anything
from
up top.
the temple
That's before the
all the way down
the
to the
endoscopic
midface. So
dissection and suspension.
So this is
And
a
this is
total
after. You see the
tightening
platysma
the
is so
smash
much
in the
tighter
deep plane.
already before we even do the posterior corset. So you see, just by lifting up vertically, essentially you see that smash in the platysma is already tightening up, and you can see the difference already. And so this is a total deep plane from the top head to the bottom of the neck. And once we've done that, we're gonna do a facial sculpting with fat, and we usually put around between 40 and 60 cc's, and these are the areas that we put in brows, the brow area, glabella, temporal, is really through the entire face, and we really sculpt the face with the fat after we set the foundation for the face. And then now we're going to do the posterior corset. We're going to tighten up the lateral platysma to the posterior mastoid fascia and neck fascia. And so now, now we've done everything.
This is posterior corset is done on this side. You see this mass is so tight. Platysma is tight. Posterior
So
corset.
everything is tight
increases
from the top of the
diameter
neck to
and
the bottom of the neck. You can bounce a quarter off of that smash and the platysma. Okay, so it's very, very tight. And so that's our procedure, and we'll proceed to close. Now, so our complication rate is very, very low. In our series of 600 over 22 years, we only had like 2%. We only had 2 hematomas, which is 0.3%, 1 seroma, 4 fat graft lumpiness, only 3 delay healing infection that requires some dressing change and local wound treatments. 1 sialocele that was treated with neurotoxin, and transient neuropraxia frontal branch is about 4.8%. It all resolved spontaneously, and we have transient alopecia of the incision site. It was 2. We rarely have to go back and resect any alopecia areas. And then we have transient asymmetry of the lower lid with scleral show that we didn't have to do anything with it. It all resolved within 6 months. In terms of our aesthetic revision rates, we have some, but not, it's very, very low. We have 3, some readjustment midface suspension, readjustment of canthal indentations, whether we adjust the midface suspension, transient cheek indentation. There were 12 of them in. There was 2%. We can just use a filler, or we can solve with a little fat transfer. Persistent nasolabial folds. We had to go back and suspend the cheek a little bit more, and persistent redundancy in the lower face and neck, and we had like maybe 2%. And here's some of the results. And in patients, this is ponytail lift type 1. Is really great for sad and hollow eyes. This is 1 year after that these patients, the eyes could be turned up very effectively, in the cheek out together as one aesthetic unit. This is how fast they heal in 3 weeks post-op, and they're really quite presentable. This is another ponytail face lift type 1. You know, we didn't do any upper eyelid skin excision. This is all non-incisional upper blepharoplasty. This is all done with the brows and the forehead area, with really no incision on the face. And the neck is the deep neck is submental incision. This is the patient that we've done with that we actually can add a tear trough implant or cheek implant through the same temporal incision. And this is 5 months post-op. And for ponytail lift type 2, is great for patients. We can create that thinner lower face and V shape shaping. And the ponytail facelift type 1, you see patients, they just don't have any stigmata of facelift at all. There's no hiking up, there's no amputation of the sideburns, there's no scars from the ear. The neck is done, removing the skin is all done posteriorly. These patients, they look great without any kind of stigmata of facelift. Again, no incision in front of the ear. This is post-op on another patient here. This is 4 months post-op. And these patients are all plus and minus a deep neck with plus or minus submandibular gland reduction. This is 52 years. This is 3 years post-op. They look very, very natural. The cheek has maintained a nice OG curve, and of course, and then the skin in the lower face and neck is removed. And this is another patient here, 67 years old, 2 years post-op. And these patients, especially it's great for Asian patients because we don't need to put incision in front of the ears at all. Asians don't heal well with a scar in front of the ear. There's another patient here, 2 years post-op, 63-year-old. I know the criticism is some people, they think that we have to remove skin. How can we have any kind of sustainable results without removing the skin? But you can. This one patient here, she has so much jowls and so forth, and we thought that we were going to have to run an incision in front of the ear, but we didn't. I was actually very surprised myself that we didn't have to make the incision in front of the ear. I thought it was going to be a type 2 facelift. This is actually only type 1. And this is 3.5 years post-op now. This is her 3.5 years post-op. So, and she's older patient, and they maintain, they sustain because it's a total deep plane. Everything is tightened. This is 4.5 years now post-op. Male patients, we can do the same. They're quiet. You have to underdo the brows and so forth. And
Okay.
And then this patient, 69 years old, 17
I'm
years
going to be
post-op.
69 in October. I saw Dr. Kao for a facelift in 2003.
2003?
Yeah.
When I
So we're
first
18
started.
years onward.
Oh my
and
God, I'm getting old.
I still got this.
You look amazing.
Thank you very much.
Yeah, I mean, this is wow. I'm actually really pleased.
I tell people all the time, they say, gosh.
So these patients, they do maintain, and I know that people tend to think that we don't remove skin. How can it last? Because the work is deep down in the muscle. It's kind of like a tummy tuck. We have to work on the musculature, so the skin was going to follow. That's it. Thank you so much.
Thank you. That was just an absolutely fantastic presentation in every aspect. So thank you so much. Before we turn it over to Dr. Kaur, I just want to give a quick plug for the annual course at the Aesthetic Society annual meeting that he teaches, as well as Dr. Kao, and he does it with Dr. Renato Saltz and Greg Albert. I've taken the course. It's fantastic. And Dr. Kaur, you've been doing it for 25 years. Is that right, the course?
Right.
Unbelievable. All right, we'll turn it over to you. Thank you.
Well, what do you say after that? That was an incredible presentation. I met Chia Chi in about 2015. He was a presenter at the American Brazilian meeting, and we just happened to sit down and have dinner and talk, and he started talking about these concepts, and I was very fascinated, being interested in minimally invasive surgery, and with my history with endoscopy. We were constantly being told by supposed leaders in our field that endoscopy didn't work, it didn't last, It was, all sorts of things. We were left off the podium in many meetings, but there were even panels that said things like the endoscope is dead. That was actually the name of a panel. So when Chia Chi came along, essentially I was already pretty fascinated with this, and as it continued to grow, I became very interested in it, and we talked about publishing this, and I told him, you got to publish this. This is really unique. It's a totally different perspective on everything, because people had tried to do endoscopic facelifts early on. People had tried doing endoscopic facelifts, switch to a different language. I don't understand this.
I think you can probably just ignore that.
It says I'm speaking Spanish. I do how to speak Spanish, but I don't. So at any rate, I was just really pleased that he did publish it, and now it's out there. So when looking at the paper, first of all, I think it was an extremely detailed presentation. He actually went into very, very minor details that normally in a paper like this, you don't get a lot of these types of details, and it's only later that you see that the author was doing something that wasn't really shown in the paper, but he's really shown everything beautifully. My congratulations to his co-author and helping bring all this stuff to light with these beautiful presentations. But I think, the most important thing is that this is just a way that he's taken a lot of things that people have worked on for years, and he's managed to bring them together with some very unique applications, that he's able to do this endoscopically. And not only is he able to accomplish it with the extreme precision and anatomy, but he's able to make it last. And we see these patients now that are many years out. It's shown the absolute effectiveness of endoscopy. And the whole reason that endoscopy is important is because as plastic surgeons, that's the whole point. We're not supposed to leave evidence that we were there. So people are supposed to see people and say, wow, you look great. Have you had anything done or whatever? And they can lie about it and get away with it. So the thing is that with a situation where people look totally normal, they don't have incisions, that's where endoscopy helps you. And it's something we really need to teach in our residency programs. I've interviewed something like 36 fellows now. And out of the 36 fellows, we've only had just a handful have even seen an endoscopic procedure. So that's something that we teach here in the fellowship. We're hoping Dr. Kao is eventually going to do a fellowship. We'll twist his arm on that. But at any rate, it's really amazing that he's brought all this together. So he's successfully brought the endoscope to the middle and lower third of the face. Now, Renato Saltz and others have been doing endoscopic mid-facelifts for some time, but nobody's really accomplished well a lower facelift in the deep plane like this endoscopically to this extent. Now, there are some things about it that I think are somewhat unique. One of the things that are unique is the extensive subcutaneous undermining all the way back to the trapezius, around to the front, through the neck, and all the way up to the ala area. And that's really, to me, adds a lot to this procedure in addition to the deep plane. He's able to redistribute all that skin. And I think that adds a great deal to this. Other than that, it's the results are just spectacular. It shows somebody that's gone about this in an extremely meticulous and detailed manner. I think it's something that we, as aesthetic surgeons, need to learn and we need to apply. I know that Dr. Kao is committed to teaching these techniques, and I think that's just excellent. I actually grew up in the day where a lot of people who discovered things like this wouldn't even show other people what to do. So we're very fortunate to have someone like Dr. Kao that's willing to share this information for the benefit of not only the surgeons, but especially our patients. Because our patients, if they start to have procedures like this, I think it's just great for the patients all the way around. So that's kind of my take on it. I think it represents a new approach, a new era, and that now we can take a lot of these things that some of the people in the past have kind of worked on, but Chia Chi sort of brought them all together and be able to do it endoscopically. And I'm excited about it.
Thank you, Dr. Kaur, for your great comments, and thank you for writing such a wonderful commentary in ASJ. I encourage everyone to read it. So we have a lot of questions piling up in the chat box. I say that we go right over to Deniz and try to answer as many of them as possible.
Thank you. This is an amazing presentation. We have about 164 people on the call. We asked a few poll questions. We're curious to know how many people do upper third endoscopic work versus middle third versus lower third. And as expected, those numbers drop precipitously. So about 50% of us do endoscopic brow lift on the call, 20% of us mid facelift, and 7% lower facelift. I don't know. Dr. Kao, did you respond to that poll? Is that just you?
No,
Are you the one?
no, I didn't respond. No.
I was like, yeah. So it's interesting, and I think that's the biggest contribution among the many contributions of this article is that we can do the whole thing endoscopically, and it just takes a little learning. A couple questions, a couple easy, just technical ones for Dr. Kao. What scissors do you use for your brow lift?
Oh, that's a very good question, because that's a very important piece of instrument. It's just a very long, sharp tip scissors that actually Black and Black has. I've been talking to Bill Black about it. So we're gonna put together a package for anybody who is interested in the instrumentation that's needed for this procedure that we have. So stay tuned. I'm working with Bill on this a little bit. So and then we're sort of planning to teach this in a formal way so that we can really pass on this technique, because otherwise it'll die with me. So we're looking at so I'm looking for a legacy of what we've done to pass on a legacy. I mean, Grady and Nicanor and Louis Vasquez, they kind of created this, and they passed it on to me some ways, and then we kind of advanced it a little bit, and then now we have to keep pushing because I think this is medicine, right? So we take care of people. So we have to take care of people in the way that best we can, and if we don't have to make those incisions and do those dissections, I think ultimately I think it'll be beneficial to the patient.
Absolutely. Couple more little technical questions. Do you use a 30-degree scope for the jawline or a 0-degree scope?
Everything is 30 degrees.
Right.
Yeah.
A few kind of decision-making things from Dr. Serrano. For a borderline ponytail facelift type 1-2, do you start with the lobular incision and then convert to pretragal if you need to, or do you just commit to pretragal from the beginning?
You mean facelift 1 and 2, you think?
Mm-hmm.
Yeah, so I usually start with just a lobular incision, right? Because you never really know how, so the trick is try to get that vertical displacement as much as possible. And sometimes you'll get like 2 centimeter, 2.5, 3 centimeters. You don't know really until you release everything, right? So, and it really depends on how well that comes up. And then once we bring this up, you'll see that when you do the lower dissection first and you'll release everything, then you pull on the skin like, oh, there's a lot of skin. I'm not sure if I can do it all without cutting in front of the ear. I'm not so sure. And then you do the upper part, you displace all that vertically, and then all of a sudden it's gone. So I don't commit the pretragal incision until I know for sure.
So it's like removing a dog ear almost at the end of the case.
Right.
And then, yes, Dr. Kaur.
Look, go ahead and finish those questions, and I have a question for Dr. Kao.
You're first in line, Dr. Kaur. Go ahead.
So, Dr. Kao, what do you think of the gliding brow lift? I just reviewed a paper on the gliding lift. And,
man, I should have gotten my questions in first.
They cited the 2 papers that were critical of endoscopic and left out about 10 others that were positive about it. So I just want to get your take on it.
No, honestly, I mean, Viterbo, who invented it, he's a good colleague of mine. You know, he's innovative. You know, Andre Arzwal with a net. You know, it started out as a dressing, but it progressed to a procedure using the net. And for me, I think that there's obviously a push. When you look at endoscopic brow lift that's being done, when you were doing it, Grady, at the time in 1992, you correct me if I'm wrong, that you guys were trying to emulate the open coronal brow lift. Everything that you were doing, that we're doing in open coronal brow lift was to, reflect the flap and then work on the corrugators, reset the corrugator, pluck it away, the depressors and the procerus muscle, and then try to emulate that, and then try to suspend it vertically like you would do on a coronal brow lift, right? So that was a great accomplishment to do it all endoscopically, and when people are trying to learn it, unfortunately, they couldn't do it well, or they couldn't, or they didn't really take in the aspect of the patient desire. Because a lot of patients don't look right with the brow straight up. A lot of it is more rotation, it's more a lateral rotation. And now people have actually realized that, hey, you know what? There's a lot of people actually is better for a lateral component of a brow rotation, a brow lift this way rather than straight up. And so patients are coming to the plastic surgeon, I want this to be like this. And so because the force of the market, the patient wants, and they want to do this, and the way that people are doing that is to do